I'd like to start by learning a bit about you. Can you tell us about your role in the myeloma care team?
Yes, so I'm a nurse practitioner, and I've been here at MD Anderson for 20 years working with patients with plasma cell dyscrasias. And so I work in collaboration with our nurse as well as our myeloma physician to not only evaluate, how patients are, what their responses are to treatment, but also to make sure that they're tolerating treatment well. And then adjusting, medications or providing supportive medications to, so that patients are better able to tolerate their therapies.
Mm. Bispecific antibody therapy is a newer therapy. How has this option changed myeloma care?
Between that and CAR T, it's really offered our patients the opportunity to utilize the body's own immune system to help fight the myeloma cells. I think the one nice thing that the bispecific antibodies have allowed is that you had a group of patients who maybe weren't candidates at that time for CAR T, either due to other medical conditions or maybe because their disease isn't at a place where we would be able to get them to CAR T, right? Either maybe their lymphocyte count was low, one of your white blood cells, and so maybe the ability to collect those T cells would be impaired, or the disease itself was, rapidly progressing. And so the patient would not be able to be off therapy in order to have those T cells collected. And so the bispecific antibody allows us to utilize those T cells to go after the myeloma cells without having to go through the process of having to collect those T cells. And so that has really changed for that group of patients. But also we have a bispecific antibody therapy that doesn't target the same receptor that the CAR T cell therapies do. So our CAR T cell therapies target something called BCMA, which stands for B cell maturation antigen, that's expressed on the surface of the myeloma cells. And there's a bispecific that targets a different receptor called GPRC5D. It's a lot of letters, but it's a different target. And so even for patients who've had prior CAR T cell therapy, we can utilize that bispecific antibody now for those patients who've maybe progressed on CAR T. And so it's allowed another treatment option for patients that they didn't otherwise have.
So, how many bispecific antibody therapies are available for people, and how do they differ?
So we have 3. So we have 2 that target the BCMA, so that would be teclistamab and elranatamab. And then we have a third one that targets the GPRC5D, which is called talquetamab. And so, we utilize the talquetamab if we want to use a bispecific therapy that does not target the BCMA. And then for patients who, maybe won't be able to get to CAR T, we might use one of the BCMA therapies. And as far as differences between the 2 BCMA, really, they're pretty similar as far as response rates. They haven't been compared head to head. And so different centers might utilize one versus the other, depending on what they have on formulary. So I would just say, whatever one, your center is utilizing, that would be the one to go with.
Why is a care partner required for patients who are undergoing bispecific antibody therapy?
That's a great question. So it's because of some of the side effects that we can see in patients who are undergoing bispecific. So similar to CAR T cell therapy, we can see what's called cytokine release syndrome. We abbreviate that by CRS. And then we also can see neurotoxicity. We don't see it to the same degree that we see it with CAR T, but patients can still experience it. So cytokine release syndrome, you can get fevers, you can have a drop in the blood pressure, chills, increase in the heart rate. And so because of that, you have to be monitored closely, because if you would start to have cytokine release syndrome, we need to make sure that we're properly intervening, and we can utilize a different medication called tocilizumab to kind of help quiet the immune system a little bit, quiet down those T cells. And so you need to have somebody that's, with you at all times, that knows you. And then also same with the neurotoxicity. Again, we don't see it to the same degree that we see it with CAR T, but that doesn't mean that it can't happen. And so you really need to have that care partner alongside of you. Plus, I think just with these immune therapies, it's a lot of information that we're giving patients. And so it's important to have that other person there to kind of hear what maybe you're not able to catch, right? There's a lot of information that's being given to you and can be very overwhelming at times. And so it's important to have that second person there to kind of be another set of ears as you're going through this journey.